yeah, and cause that desensitization. Now, I think what we could also always talk to the patient is, how is this pressure? If the patient says it's a bit too much, just back off a little bit. Because remember, there are two things that happens with manual therapy. We're getting this neurophysiological effect, either through that gate control theory, what you've learned in your undergrad studies, or diffuse noxious inhibitory control system. So diffuse noxious inhibitory control system, this is a bit more stronger stimuli, whereas the gate control is a bit more gentle. So if you really want to go into that depth of how pain reduction occurs. So I asked the patient, how is this pressure? Because some people, as you probably experience, like a bit stronger. And that's okay, so we can use stronger pressure. So if you can tolerate, that's fine. So use large amplitude, around 45 seconds. Then have a rest, talk to the patient, feels okay, okay, another 45 seconds. And on day one, we usually do around 3 sets of 45. I try not to over-treat, because sometimes what happens, you get the neurophysiological effect, but then if you just push too much, the pain goes back up. So I'd rather do a bit less, and then monitor within that 24 hours how they respond. And tell the patient, look, you may experience a bit of post-treatment soreness, because we move things around a little bit so they don't get worried too much. Because if you wake up in the morning and they still have a little inflammation, or it's worse, maybe it's a physio done something to me. So pre-warn them. So it's all about the communication as well as part of what we do with treatment. Okay. So yeah, so we do that 45 seconds, large amplitude, and around 3 sets of that. Okay. Any questions? So can we try this on the patient and just use again that kind of like around 45 seconds, give each other feedback. So because everyone's tolerance to pain is different, isn't it? Like I said, some people like stronger, some people a bit less. So when you communicate, it's much nicer, so that people think, oh, he listens to me, he hears me, he really cares about me. All these factors really quite important. Okay? Let's try this one.
Sorry, we have a question in our group just now. If the person is doing a flexion left side bend and it's causing a trouble, and then when we assess in a neutral position on L2, L3 facet joint, and it's not painful, or throughout the whole lumbar, it's not painful. So could it be motor control issue?
So if you assess active movement, it's and combined movement, and that's painful, but when you do your accessory finding, it's not painful. Well, it's probably not the joint. I would think it's not the joint, and maybe it's even non-mechanical pain. So we'll look at the different patients, from acute to subacute to chronic, and maybe that will make it a bit more clearer. But yeah, so if I push on the spine, there's no pain. So probably the nociceptive driver is not the joint. Okay.